Patients back. Show of hands, okay? Frequent ostomy appliance liquid, leakage, skin complications, dehydration, okay, you've got all above. Well, yeah. So, you know, the clinical burden is a low urine output, which leads to dehydration, can lead to electrolyte imbalance, kidney stones, big problem, okay? And then, of course, AKI, which can go to CKD, which can go to dialysis at some point. Being dry makes you super tired. In fact, when I have a patient with high output or short bowel, they tell me how tired they are. The first thing I'm thinking is they're not hydrated enough. That's the first place I go. The leakages, the bag bursting, and of course, people don't want to leave the house if they're afraid of these things happening. So what are the clues? Well, your patients aren't making enough urine. If you leave this talk with nothing else, it's how much urine your patients need to be making to hydrate themselves. And this is where the money is, okay? We want patients' stool output to be less than 1,500. Our surgeons actually have just decided that they want it less than 1,200 now. Well, they have a life. I mean, can you imagine 1,500 mils of stool a day? Some of you may make 1,500 mils of stool a day. I know I don't, and boy, that would really be a bummer in my life. Dark urine, soft target, but it can be suggestive of dehydration. And what I ask patients anytime I meet them is like, have you been admitted anywhere? Have you been to an ED anywhere and gotten IV fluids? Because they don't always, you might say, have you ever had dehydration? They may not know that that's why they were admitted. So you have to ask it a few different ways. Anyone with recurrent kidney stones is a tip-off that they're not adequately hydrated. Their creatinines are going up is a bad prognostic sign. You know, the thirst, dry mouth, dizziness on standing, etc. So what causes high output? Well, if they are fortunate to have intra-abdominal sepsis, that can cause a higher output. Anyone with short bowel syndrome, some of this patient population they actually have short bowel syndrome. Surgeons never want to say exactly how much they took it. And I didn't really take out that much. You know, often we find out it's actually a little more than they said that they took out. Proximal stomas, a proximal stoma or a proximal fistula, you guys, is short bowel syndrome, period, okay? And then if you've got poor quality of remaining bowel, they may not have short bowel, but they act like they have short bowel, and you have to treat them like short bowel. And a GI bug, of course, you know, C. diff causes all kinds of havoc with stool output. Carcinoid, hopefully you don't see a lot of that. Recurrent active disease, sometimes our patients are not quiescent. And then outflow diarrhea, and you know what outflow diarrhea is? You know, you got like an obstruction. It's your nursing home patient with constipation. That's outflow diarrhea. They come in, they're super constipated. And this is the international sign for the GI tract. I want you guys to remember this, okay? So if you've got a tight stricture or narrowing or a tight ileostomy or jejunostomy, basically the bowel, it wants to peristalse. That's its job, and it's trying to peristalse against this obstruction, constipation, whatever it is. What happens is the bowel behind that area is going to dilate. And as it dilates, it's not happy, and it self-secretes more fluid into it, which oozes out, and the patient perceives it as diarrhea. Be careful in your nursing home patients who come in with diarrhea. They may actually have diarrhea. And then a new med that has been started or stopped, and this is one of the problems I have with some of my short bowel patients. They run out of their codeine, and they forget to call us. 3 weeks later, they're like, my output's 3 liters again, and they said, I forgot to let you know my codeine has run out, and they're down in Southwest Virginia, 6 hours away. So, you know, it's a problem. So we're like, stay on top of it. So the first thing we want to know is what's their anatomy really, okay? So how do we find that out? Well, op reports. How many of you guys have op reports that go, took out 35 centimeters of distal jejunum and 165 centimeters of proximal ileum, and colon is left. It's like took out some small bowel. Like how many? United cardiovascular surgery took out some heart. But it's okay for our GI surgeons to say. Now, fortunately, our surgery team at UVA has so gotten on our surgeons. They're really good about writing. I think it's like, oh God, I can't handle another call from one of those dietitians asking me about that link. So they're actually quite good about it being put in there. But op reports do lie. Small bowel follow-through is something that we do. If we don't have good outcome reports, we're not sure, we just do small bowel follow-through. We have a really good GI radiologist, so we get transit time. So if you've got somebody with a 5-minute transit time, you got your work cut out for you, let me tell you. And they can give you a gross idea, not super clean, but a gross idea of the anatomy. And then abdominal CT, you can get it from that too. And then, of course, you also want to know their past medical cerebral history. Heaven forbid they have chronic pancreatitis and are pancreatic insufficient on top of this. Now, this is a thing I do because I see a lot of complex GI patients, and there's no way I can remember their anatomy. And that's the first thing I need to do when I'm seeing them in clinic and I see stuff going on. I need to think about what their anatomy is. So once I determine their anatomy, at the top of every epic note I put in on that patient, that anatomy goes at the very top. And then the other thing is that my gastroenterologists and fellows also know that they can look at my notes, any of my notes, and they will be able to find the anatomy at the top of the note very cleanly. I want to know weight history. Are they losing weight, or can they just not hydrate themselves? So when you think about these patients, you're looking at it, can they nourish themselves? Can they hydrate themselves? Two very different things. And what happens with short bowel is like, they malabsorb. But people, if you don't think about the hydration piece, this is what gets our patients into trouble. So it's really two things you have to achieve with them. Goal urine output, 1,200 mils. If you've had a kidney stone, you just bought a 1,500 mil urine output. Okay, we want you making more urine because you already showed us you can form stones. And if you've ever had a stone, I've been in the ED with my husband twice. Why is it always in the middle of the night that he had a kidney stone? And it's not fun. It's not fun. So anyway, I read a lot about it the second time because I'm like, I'm not doing this again. And then here's the other thing. Our wound and ostomy nurses are fabulous at EVA. Here's the problem. That they go in, they're doing pouch changes and all this stuff. So this last patient I was following, and I'm like, oh man, the gut swelling we're doing, it's working. Look, I can track. Their stool output is dropping so nicely. And so then I'm going in to see the patient, and the wound and ostomy nurse is coming out. She's walking out like this, and I'm like, what? She goes, oh man, just like this thing is leaking all over the place. You know, it's like we can't keep a bag on. And I'm like, how long has this been leaking like this? Oh, like for the last 3 days I've been called to see this patient. And I'm like, there's nothing in Epic that has said, and me and the team are thinking we've done a great job getting this patient under control because no one has documented that the bag is leaking and spilling all over the place. So make sure you ask your wound and ostomy nurses to record that so that when you look at Epic, you're getting a real deal and not you think you're doing a good job. Patients need to know what to expect when they have a new ostomy. So one of the things we did when we started this, like the last 8-10 months, I've been working on a team of multi-disciplines to fix this problem we've been having. And so, and what we realized is patients weren't being told what they should expect with a new ileostomy, what they should be putting out. And it's around 1,200 mils, you know? So if they're putting out a lot more, that's a red flag. They need to call somebody. Jejunostomy can put up to 6 liters. Hopefully they're not, and I don't usually see that unless there's usually a problem. And that usually calms down quite a bit too. And then the colostomy, I don't worry about this because they do fine. Any little bit of colon just sucks up water like crazy. So how do we differentiate between osmotic and secretory? Because some of these patients, you know, our short patients, often it's an osmotic problem, and how you approach it is very different than you do secretory. So a lot of our ileostomy, new ileostomies, if they come in with, if they become a high outputter, it's a secretory problem for whatever reason, and so we have to go after it in different ways. How do you find that out? You make them strict MPO, zip, zilch, nothing goes in for 24 hours, and you watch their stool output. If their stool output drops to nothing, it's osmotic, easier to treat. If, however, their output continues to be quite high, you have to go after it with different drugs, like anti-secretory agents, to get it down. And hopefully that's going to get better over time as the bowel adapts. But often they need to be hit pretty hard with some of these agents. If you suspect malabsorption, you're going to need to do a 48-hour, 72-hour fecal fat collection. If it's Medicare, you have to do 72-hour if, in fact, this patient could be on the launching pad for TPN if they're Medicare, okay? And then that means patients have to ingest. 50% of the time when fecal fats are ordered at UVA, they're done wrong, okay? Because what happens? the patient gets put on a fecal fat collection and 100-gram fat diet, and then usually a gastroenterologist comes in and says, I'm going to do a procedure. I'm going to do a procedure tomorrow. I want an MPO or clear liquids. And you're like, wait, either we have to finish this study or we need to abort the collection because you can't malabsorb fat if it's not going in, okay? All right, so there's no data for this. I made this up. And the reason for that is that we're desperate. When you have somebody come in with high output, all we care about is getting that output down and getting their urine output up. And so I've taken the things that are known to be highly osmotic and diarrheagenic, and I just take it out. We can always add it back, but let's just get them stable, because that's what we want to do. And hopefully we can stabilize them so they don't need IV fluids at home, but that's what we're looking at if we can't stabilize them. So we get rid of the desserts, jello, syrups. Watch out. I walk in and the patient's got pancakes. Oh, but they have diet syrup, okay? Great, probably worse with sorbitol in it. So you gotta watch out. And then everyone wants to help these patients who are having all this liquid. They're like, oh, maybe they'll absorb it better if we make it in liquid form. But liquid meds often have sorbitol or other sugar alcohols, which again are very diarrheagenic. They need more salt. So in our diet instruction, we talk to them about taking in more salt, because if you've got an end ileostomy or jejunostomy, you lose a boatload of salt. You lose about a teaspoon of salt per liter of stool that you put out. So I tell them, pretzels, chips, they're your friend, eat a lot of them. I'm like, oh, but my heart doctor told me, this trumps that. So you've got to get more salt in. If you have somebody who's really not sure what's going on, you can do a 24-hour urine for sodium to see if they're sodium deplete, because if they are, they really are going to you're going to need to be more aggressive about sodium. We don't do that very often, just once in a while. And then the hypertonic and hypotonic fluids, I'm going to talk to you a little bit more about that, and oral rehydration fluids, which are not a panacea, but they can be useful in some patients. So the hypertonic fluids, they kind of get it going and coming. So why do we limit the hypertonic? Because they pull fluid into the bowel. The highly osmotic juices, sodas, etc., pull fluid into the bowel, and then out it goes. The this is not to slam Abbott or Nestle or anybody else, but Ensure and Boost, the number of patients that I see on these products, and they come into clinic and they go, and every time I drink it, I have so much more diarrhea, but my doctor told me to drink it. And I'm like, we need to have it on the label. Not for use in short bowel patients and high ostomy. Because, they're fine for anybody else, but this is just not when they should be used. And yet everyone gets put on it. Like on the lister, just 2 weeks ago, there's somebody who said, oh, I put my Charbabay on and they needed to gain weight. And I was like, oh, no, not again. Then hypotonic fluid, lesser of evils. You're going to have to negotiate with these patients, because let me tell you, a lot of them are not going to drink that oral rehydration therapy. But the thing about the hypotonic fluids is, the GI tract wants to be isotonic. That's its job. So basically, it's going to pull sodium now into the GI tract. Sodium doesn't travel alone. Sodium is going to pull water with it. So again, they're going to have more output. So but you're going to have to compromise anywhere. Compromise with the hypotonic fluids. And then we try to get patients to drink less with their meals and to sit more between their meals. I have some patients who drink so much, I will finally say, I know this is driving your output, so I beg you for 24 hours, just 24 hours, I want you to drink a half a cup of fluid at your meals and with your meds. So a half a cup 3 times a day. That's it. And I want to show them the sheer volume of drop in stool that we will see when we do that. And in fact, some patients, the therapy has to be, they have to really limit the volume of fluid that they drink when we send them home. And of course, they'll be supported with IV fluids. And again, that whole goal is that 1,200 mils a urine. Now, oral rehydration therapy are not for everybody. It doesn't decrease diarrhea at all. It just allows absorption in the jejunum. That's where it takes place. You've got to have the right combination of sodium and glucose and water for this to actually work. And again, it doesn't work in everybody. It's not a magical bullet. Some patients prefer it as ice cubes or popsicles. And we've had a couple of patients who we had pegs, and we just infuse it during the night, and we sidestep the central line. If there's ever a patient where we're talking about putting a central line in, we would admit them, drop an NG tube, always as high up as possible, and we would run it in during the night. And if we don't have them getting up all night to stool, which would defeat the whole purpose, then we would put a peg in, and we would not put a central line in, and we would give them oral rehydration therapy during the night instead of the risks of a central line. And there's a lot of commercial products, they're quite expensive. And then there's a lot of recipes available, and this is the book I was telling you about that was paid for by Shire Takeda. And I have a bunch of recipes in that book. It's available free to anybody. Now I want to show of hands. How many of you would prefer to take 16 to 20 tablets a day, and your stool output is still over 15 ml a day, or would you like to take just 4? How many want to take 16 to 20?
I like it.
Yeah. More drugs, the better. Okay, so why is it that nobody actually does this? It's like no one wants to take that many drugs. And so that's why, remember I told you my goal when I see a patient with 34 pills is to get them off those 34 pills. I can sometimes drop stool output by just eliminating 22 meds. Why? Because all the stuff they're drinking those meds with is adding to that output. You know, it's like you've got to think about all those pieces. So whenever I meet a patient, I want to know everything they put in their mouth, and it comes out in dribs and drabs. It's like, you know, you find out halfway through clinic. I just had a patient where she's like, I got the med list, like, 3 meds? That's all you're on, 3 meds? She was, yeah, she was very proud of herself. And then over the course of the thing, she's like, oh, but I'm also, I am taking a PPI. And I'm like, well, it's not on. And then, of course, there's like 3 more meds she was on she forgot to tell anybody about. So I ask it a million different ways. And then, you know, no med is good if it's not given. And PRN meds aren't given. I spend my life dealing with PRN meds and getting them scheduled so that they actually can do their job. Timing in relation to meals. Some of these drugs need to be taken before meals, so you got to plan it when the meal's going to come in your hospital if you're talking about an inpatient, and you got to get them scheduled at the right times. And sometimes the form is important. Maybe a capsule's going to go right through them. You know, I love whenever I see a new short bowel patient and they're on sustained release, controlled, delayed, extended, it's like, why? You know, come on. And then watch out for the elixirs. And then always ask, are you getting efficacy? If you're not getting efficacy, either change the drug or get rid of it. Always, you got to know if it's available. Tincture is one of these big problems. It's not available in most pharmacies anymore. So you don't want to get somebody stabilized on tincture opium and they can't get it when they get home. And then are they still needed? Again, I see patients who have been followed by, they have, you know, typically at the hospital, they've got 5 specialists. But because short bowel is the biggest thing, or the high output ileostomy is the biggest thing in their life, that's the person that they're seeing. They're not seeing all the other people that have put them on all these meds, and they're now half the size they used to be. So they might not even need some of those meds anymore, but since they haven't gone back to their doctor, they actually haven't been taken off of them yet. So I will often say, okay, it's time to call your cardiologist, see if you still need to take this, or get in to see them, because I suspect you don't need it anymore. Because someone has to be accountable for that total pill count. And a lot of times the physicians are so busy that I work with, and they're like, I didn't order that, I'm not touching it. But it's like, since I'm dealing with this output and I'm trying to fix it, that may be the ticket, is to get them off some of these drugs so they don't have to take, you know, the fluid with it. Okay, which meds are most often employed to help control high output? A, ibuprofen. B, cholestyramine. C, Imodium and codeine. He's going to answer. Pancreatic enzymes? No. All right. So, I love opioids, and you know, wouldn't it be that I am intimately involved with a patient population who often is on very high dose opioids in an era of an opioid epidemic? So it, of course, makes it much more difficult for our physicians. The hassle factor is huge now to get these on board, that they're so effective. And the thing about opioids is they delay gastric. They just slow everything down, which is exactly what we need in these patients. It just disturbs the migrating motor complex, slows the transit, the increases anal sphincter pressure, inhibits water and electrolyte secretion, yes, and it increases fluid absorption. All of these things are beautiful. So, but before we start the anti-motility agent, we want to make sure they're not C. diff positive. And you all might, like, it's like, how many of you think, can a patient with an ileostomy or jejunostomy get C. diff? How many think patients with an ileostomy or jejunostomy can get C. diff? How many of you think? Yeah. Well, it's amazing how many physicians don't think that. So, because these patients get referred to me, and I'm like, okay, I really think we need to put this patient on coding, but let's just make sure they're not C. diff positive first. And I get the, thanks, darling. They have short bowel. Do you know what short bowel is? And they don't have C. diff. And, like half of them end up having C. diff, okay? The lady I saw this summer, poor thing, 3 years, horrible C. diff. Finally, she actually found my book, and it's like, check C. diff first thing. And she had her PCP check it. He begrudgingly checked it. She was C. diff positive. And after 2 weeks of treatment, her stool output was down from 10 to sometimes 19 a day, was down to, like 4 to 5, something like that. It was amazing. She was in tears when we met her in clinic, because she was so happy. She was happy.